Hey guys, this is only, I guess you only want a half hour. This is like a lot longer. I mean, this is longer than a half hour, but I think we can pare it down and skip over some stuff. This was made for the fellows, pulmonary fellows, so maybe some of it's not as interesting to you all. So, okay, so basically the outline of the talk is just a case and the pathophys, which we can kind of go quickly through, and the clinical assessment, which I think is probably most important for you guys, because you do the initial clinical assessment. Well, I'm Joe Gorga. Most of you guys know me, I think, right? Everybody's come to the ICU at some point. Yeah. Okay. Okay. And then the event, it was sort of what they asked me to talk about. So maybe we'll just spend a little more time just on the initial event setting, because that's kind of where you guys sometimes struggle with asthma, because they can be difficult. I mean, we had a case recently where a guy had an impaired needle thoracoscopy done. We don't really know if he ever had a pneumo or not. We never found out. I suspect he didn't, but it's tough. So anyway, the event management is challenging, and you're in the early going with asthma. And then salvage therapy, we can just whip through salvage therapies, especially ECMO and BAL, but you're not going to get too involved in that in the ER. So anyway, okay, this was a case of mine. Like the first minute I was attending, it was terrible. This is 25. This is a classic story for you guys. A 25-year-old obese woman, child with asthma, never went into remission. Never been intubated, but it was kind of worsening control, not really on any control or medicines. Recent URI, non-compliance at times with Symbicort. She wasn't taking it all the time, found to be wheezing. She does what happens to a lot of asthmatics, that she initially improves, because beta agonists work on these people. But unfortunately, beta agonists wear off very quickly, and steroids don't work that fast. Steroids take 6 hours to work a lot of the time. So what happened to her is she was like doing so well. She was assessing her per discharge, walking around the ER, and she collapses. And she goes to respiratory arrest, and she gets intubated. And this happens, thankfully not every week in the emergency department, but it happens frequently. And they're like, oh, she was doing so well. Oh, not anymore. And so you see her initial chest x-ray, which is normal, and that way you can see that she was standing up. So obviously she wasn't that sick. She has a PA and lateral, so she wasn't very sick. And she was on the ASI. She was in the asthma remission. So she remains extremely tachypneic with high peak pressures, air trapping, following intubation. She's acutely acidotic. She gets the whole cocktail of epi, continuous nebulized albuterol, MAG, everything. It's sedated with propofol, and then we're there, and we're like, oh, just paralyze her. So we paralyze her in the emergency department. And there's her post-intubation x-ray, and it still looks okay. I mean, there could be something like brewing down here, maybe, that we're starting to see, but it gets hard to tell. And here are her ABGs. They're not encouraging. So she gets intubated. Where's the intubation? All right, she gets intubated like just after 1 o'clock. Actually, no, this is post-intubation, because she never had an ABG, and we'll go over why they don't need ABGs. The only time I'm going to tell you that you don't really need an ABG. And you can see that she just kind of gets worse before she gets better. And I'll go into like sort of why I shouldn't have overreacted to this. But I was new at this, and you see the pH of 7.04 and the PCO2 of 104 at 7:30 in the evening, and you get a little worried when a 25-year-old girl. So it turns out I probably was okay, but anyway, I'll go over what happened. We actually ended up putting Heliox on her, and I'll go when I talk about salvage therapy. I'll tell you a little bit about Heliox. It's just a helium oxygen mixture that creates laminar flow. It's not really great for asthma. So she slowly improves. And we stopped paralyzing her on the second day, and she's extubated day 4, she's in my clinic, and it's a happy story. Her mom and my patient now too, because they think I'm like amazing or something. And she just got better, she got better. So, okay, we know asthma prevalence is increasing. We know that this is a little slightly older data. A lot of this comes from ATS. They have a thing called Expert Clinician, and they go over major topics. If you ever want to read pulmonary stuff, it's a cool thing to read. You see about 10% of admissions go to ICU. That's probably not true in our hospital, but maybe nationwide that's true. 2% get intubated, so we're dealing with the minority of patients here. Mortality is due to complications of gas trapping. So that's barotrauma, hypotension, and refractory acidosis that we were seeing in my patient. That's how people die. So pathophys, I don't want to spend too much time, but it makes sense in terms of why they get worse before they get better. So you get airway wall edema and mucus gland hypertrophy, and what this leads to is diffuse mucus plugging. And when you plug off all your small airways, all you do is dead space ventilation, and and your PCO2 goes up. Because none of the gas you're pumping into someone's chest with the ventilator is actually reaching the alveoli, and as a result, you're just exchanging, you're not exchanging the gas. So you're just ventilating. Because remember, the conducting airways don't do gas exchange. And you have about 150 cc's of conducting airway, and then you get into the respiratory airways, and that's where your gas exchange happens. And you never change that 150 cc's. Your trachea and your mainstem bronchi are the same, no matter what you do. It's just a matter of recruiting the alveoli, and you can't with these people because they're diffusely mucus plugged. And it's not just mucus, it's inflammatory. It's just epithelial cells, eosinophils, fibrin, proteins. People used to bronch these people acutely, and they used to die during the bronchoscopy. They're not said because you remember these people dying during bronchoscopy. So we don't really do that much anymore. It's under the salvage therapy, but yeah, it doesn't really entertain it that night. So all these things combined to cause increased airway resistance, worsening BQ mismatch. Now we say little shunt, and you'll probably notice from your own clinical practice that they're not difficult to oxygenate. You're never like, oh my God, this asthmatic, I can't oxygenate her. That's not the problem for him. The problem is peak pressure, is ventilation, not oxygenation. Oxygenation is not a problem. In the dead space, I kind of went over about the conducting airways. Okay, but these are a lot of times young people, and they're able to compensate just with their respiratory rate. They're young and they're strong, and they can usually get through it. That's when only 2% get intubated. So gas trapping. So this is like airflow limitation. Same thing. It's the same pathophys. You have bronchoconstriction, airway edema, mucus plugging, and then you get increased work of breathing and hyperinflation. So let me just show you the graphic, which is a lot better than the text, which just shows you the normal lungs, are here, and you're coming down to zero flow, zero volume down here. But when you terminate your breath before full exhalation, you don't fully expire. This gas stays in, and sequentially your lung volumes go up. And this is the classic explanation for how you trap air, and this is going to be the volume that's trapped. And what that does is it increases thoracic pressure, decreases venous return, and it causes all sorts of hemodynamic problems. And then it can ultimately lead to pneumomediastinum, pneumothorax, barotrauma, all the things that can happen. Okay, so auto-PEEP, intrinsic PEEP, dynamic hyperinflation, all the same thing. So these are just like things that we say, they sound very academic and whatever, but they're all the same. And it's basically what I just described. That's it. Skip. Let me go to this lecture in a bit. I looked at it a bit yesterday, but okay. So you can measure the end expiratory flow if you want to. I don't think you guys want to. If you want to, they have to be paralyzed. Because if they're actively breathing and you're doing end expiratory hold, it's not helping anybody. So if you've already got them paralyzed or deeply sedated with propofol or whatever the thing is, there's a little button on your ventilator. I don't recommend going pressing buttons on the ventilator. You don't know what they do. But this one's an end expiratory hold. It does just that. I'll explain it in a second. This bottom line where it says 20 ml per kg predicts hypotension or barotrauma, this is from the old days when they used to hook up big bags to ventilators and collect all the CO2 and then measure the amount of gas trapped. You won't ever do that in your life. You'll never see anybody do that in your life. That's for somebody like in a lab with a rat like in a bag. It's not for us. So don't worry about that. That was for pulmonary fellows to understand like where the data comes from, and like you guys probably aren't as interested in that. So, okay, measuring gas trapping. Okay, so this is called PEEP. So basically what this is you put the end expiratory hold. I'm going to show you the graphic is better than the text. So this is basically the idea, is that the top is normal, right? And all that an end expiratory and inspiratory hold is create a column of air that's supposed to communicate between the alveoli and your ventilator. Theoretically, when you stop flow and nothing is flowing, it will equilibrate between your alveoli and your ventilator. And your ventilator will then tell you this is how much pressure remains. Now, if you have diffuse mucus plugging and everything else, does it reflect alveolar pressure? Probably not, but it's all you've got. So basically what it is, like the top graphic is normal. So, they got 20 cc's at the end of inspiration, but then at the end of expiration, they fully expire and the pressure goes to zero. Okay? So, when you have airflow obstruction and you can't get it all out, you have an end inspiratory pressure of 35. So you got 35 in the alveoli. Then you hold at end expiration, and you find out that only 20 actually went out and 15 remain. And so what that will be is you put that end expiratory hold, and then you have to. You guys have those terrible Drager ventilators in the ER, unfortunately. It doesn't even do it this well. On our servo ventilators, it gives you a nice graphic that shows you that. And when you hold it, you have to hold it for about 5 seconds. It will tell you how much pressure is in there. If you have PEEP If you have trapped air of more than 15 or 20, you might want to disconnect the ventilator and let that gas out, because that's where you're starting to develop bowel trauma and hypotension. Okay, and here's what is important for you guys to recognize. You're going to see this. This is the graphic that you want to know about. This is the flow graphic, and under Draeger, it doesn't come up automatically. For some reason, it gives you volume and pressure. Volume is not very important because you can just look at what volume is going in on the top line of your Draeger, right? Everybody know what I'm talking about? Just a picture of the Draeger. Everybody has seen that vent enough? The Draeger is the one with the big panel that you guys have in the ER, right? Not the one with the nice screen that you touch, right? It's not a touch screen, it's got the wheel. So, what I want you to see is that inspiration is a nice old school square waveform, which I'm going to talk about in a minute. This is how we used to do ventilation before fancy ventilators and PRVC and whatever. So it pumps the flow in all at once. It holds the pressure to get the volume and it releases. But what I want you to focus on is the expiratory limb of this waveform. So what this is showing you is normally you come to a zero flow. That signifies that you've fully expired. It doesn't mean you have no air traffic, it just means you're fully expired. You can fully expire and have trapped air, actually. So, but if it's not getting worse and worse, you're probably not dealing with a dynamic process that's going to give you a problem in the next hour or two before we're all over the case and have the patient upstairs and whatever. But what you don't want to see is this air. So what you have is the expiratory limb going like this, and then the guy or girl breathes in before he or she is fully expired. And not like in that sense. And it doesn't sound so good. So we are looking for full expiration here, but anyway, so if you see that getting worse and worse, that's what you want to look at. You want to see this, this curve hopefully come to normal, and if possible, not have this getting worse. Now you'll find this one's very tachypnic, so just think about it quickly. You breathe 15 times a minute. How long do you have for each breath? Breathing is easy, okay? 4, okay, right, good. So typically you inspire for a third of your respiratory cycle and you expire for 2/3. So it gives you a second to inspire, which is normal, and 3 seconds to expire. So double that to 30. Now how much time you got to breathe out? 1 second. Make it 60. How much time do you have now? Half a second. So like when your respiratory rate gets that high, you can't empty your lung, you don't have the time. So you want to slow down the respiratory rate one way or the other. So we'll go about how you do that. So this is a lot more complicated than this slide says, and there's a lot of words on that slide, and it's much more complicated than this. But the idea is that when you have dynamic hyperinflation, intrathoracic pressure decreasing its return. Don't forget the RV fills during inspiration, okay? So when the RV fills and it's really getting full, you're going to have septal shifting to the left and you're going to decrease LV filling, okay? And that causes a problem for cardiac output. So you also increase afterload massively, okay, by impairing systolic emptying. So you have multiple effects on decreasing cardiac output, and this is how you end up in circulatory collapse with this disease. It's not usually that they're in shock and hypotensive, usually due to tremendous intrathoracic pressure. Does that make sense to you guys? Yeah? You put lots of pressure in the chest, can't get the blood in, can't get the blood out. It's the simplest way to explain it, okay? So pulse paradox is going to be very difficult to measure on these patients. They're going to be very tachycardic and very tachypnic, and there's no way you're going to have a, that's just not practical. Okay. Let's do a little, so that's sort of the background, right? So the clinical assessment, yeah, good, I'm racing through this. So I'm good at talking fast, so you're people talking fast anyway, so I can do this fast. So this patient is someone that you're very, very familiar with. This is an anxious, breathless, fatigued patient that's sitting upright in bed. You call me for a consult and the asthmatics lying flat on their back, I walk out of the room before I even see the patient. I mean, I don't, but in my mind I'm like, okay. Because there is no asthmatic in distress that's laying on their back. They just don't do that. And they actually have studies that have looked at ER stuff like this. They sit up to advantage themselves to breathe. They just can't lay back like that. It worsens their intrathoracic pressure from their abdominal contents. It unloads them. So like when they sit forward, it unloads their abdominal contents and it lets them breathe better. So rapid assessment, you guys know all this already. This is like stuff that you always tell me when you present them anyway. Like prior intubations, history of near-fatal asthma attacks. The reason why history of near-fatal asthma attacks are important is that they just don't sense they're sick. They come and they're dying, and they don't have any sensation for their symptoms. And that's why we get them in respiratory arrest. Because they use albuterol 1 million times a day, they blunt their hypoxic response, they have no response to bronchodilators anymore because they use them constantly. They just don't sense their symptoms. And they have diminished patient perception of dyspnea. So if they have hypercapnia presentation, obviously, if they have pneumothorax, this stuff's obvious. If they have lots of chronic steroids, like everything, psychiatric patients do worse. They don't tell you what's wrong with them, and they don't make it easy. They make it hard. And so psych patients, as you guys know too well, be extra vigilant with psych patients. Besides the fact that you're under the microscope with them too. Nobody wants to see a psych patient fall through the cracks. Okay, so physical exam. They're sitting upright. They can't lay down. They have altered mental status. Obviously, vital signs. Simple. So you want to assess in your physical exam before they even have a chest x-ray. They just come in, assess for subacute emphysema, put your fingers in their supraclavicular spaces. They can have crackles there, and they have a pneumothorax. That's one that you could actually find. Deviated trachea, I suppose you could do that part of physical exam if they let you. And don't forget that upper airway obstruction mimics this whole story. They look exactly like asthma. They're wheezing. It is diffuse. They're in distress, and their vocal cords are just closed. You won't know what happens until you intubate them. So, we'll figure it out once they're intubated. Their peak pressure is normal until they lose upper airway obstruction. It happens to everybody. So they're going to be wheezing, but wheezing is good, not bad. We like wheezing. When I come to the lady or the man is wheezing, that's good. It's a silent chest. It concerns us. That's how that guy got a needle in his chest the other day. He had a silent chest. Nobody could tell what was going on, and his peak pressures were through the roof. His plateau was through the roof. Everybody got scared. Somebody stuck a needle in his chest. We ended up with a chest. He did fine. Don't worry. He got a chest too. We got it out. He did fine. So he was a nice young guy. It wasn't too happy about it. So, don't forget that older patients, they can have MIs over this. So don't forget that they can end up in heart failure too, but that's the older patient, not my 25-year-old girl. Okay. All right, this is kind of stepping back in a way, but like FEV1, you're not doing it on spirometry, but you can do peak flows, but on this very distant patient, they're not doing peak flows, obviously, so forget that. Deep inspiration, so you say, take a deep breath. Try not to do that to these guys too much. Just listen to them. Don't ask them to take deep breaths because actually they get a worsening bronchospasm, coughing attacks, everything with deep breaths. Don't do it. If you can't hear it, you can't hear it. If they have a silent chest, that just means they have a silent chest. It's not good, but it's what it is. Now you already know the FEV1 50%, goes to 75%, you discharge them. Less than that, you admit them like that, you already have. And you can use the peak flow serially to see if they're going to do well and if they can go home and what. I know you guys already do that. Blood gas. All right, so this is something nice to tell the emergency department. Little to no role in mild to moderate asthma. But that's not me. You're not calling me for mild to moderate asthma. So when you're admitting to the floor and the floor resident says, we need an ABG, you can confidently tell them you do not need an ABG. This person is fine, and they're clinically well, and they just need to be admitted and get their surge. They don't need an ABG. But if you call me and the person is like in respiratory arrest, I think it will be helpful for you to get the pH. So, the degree of hypoxia is not, we don't need ABGs for hypoxia anymore unless you have a horrible waveform, you just don't know what's going on and you don't want to know. You got a good waveform on a pulse ox, it's good. You know that they're not hypoxic. Early you expect respiratory alkalosis, this is encouraging. Mild hypoxemia, this is encouraging. You can have non-gap acidosis that's going on for a while because they'll waste some bicarb. Right? They'll breathe out their CO2 and they'll waste their bicarb. Increasing obstruction leads to exhaustion, blah, 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 and then they can't ventilate and their CO2 starts to go up. Hypercapnia is not always an indication for intubation. I think more important is their mental status and their clinical story. You can try BiPAP, the data doesn't support you, but we certainly know experientially that it works for a good number of patients. I think BiPAP is a reasonable choice for a person that's awake and alert and can cooperate with you and isn't so sick that they're pulling off the BiPAP and they're agitating or whatever. That person is not a candidate for BiPAP anymore. Anti-gaps usually do the lactate, but just don't forget that there are these people that have B-lactate. We don't do a lot of continuous albuterol, I notice. You guys don't put them on an hour of albuterol in a row very often, but you can. You just, it's a choice. But they can also get lactate from albuterol. It happens. But your lactate is going to be negative. It's not really going to be there. It's going to be low, but the gap's going to be there. Okay. All right, here we go. Actually, interestingly enough, a lactate in asthma early is a positive sign. Strangely, it just means I think it means that they can compensate with work. It's like jogging. It's like they can do it. They can quit. Yeah. So Okay, radiology, again, I can tell you again, although I'm not going to tell you this to tell medicine this, because we're going to get all anxious. Really, chest x-rays are useless in mild to moderate asthma. They're all normal. They did this study that's here, Stephen Sons, like the god of oral disease, and in the 80s, so I guess 1980, he just looked at 90 chest x-rays from asthmatics, 50 were normal, 33 had hyperventilation, 6 had minimal markings. Okay, that means that there was no action taken on 89 out of 90. So really, the x-ray doesn't tell you anything. So, I mean, you got fever and purulent sputum and other things like that, and you're concerned for pneumonia, of course you get it. We're talking about straight up asthma. Like I was at my friend's house and they have a dog, and I'm allergic to dogs, and now I'm wheezing. Really, they don't need a chest x-ray, but if you're being took to medicine, they'll appreciate it. No skin off your back, just get an x-ray. I know, of course, if you have mediastinal signs like chest pain, you get the crunch above there, any concern for subacute emphysema, low blood pressure, of course you're going to get a chest x-ray. Those are indications for an x-ray. Okay, I think this is just interesting, so I put it in. There are two patterns for asthma attack, and I think you're going to recognize both these patients. One is my lady. Young woman, predominantly, poorly controlled disease with moderate severe obstruction if they have PFTs, decreased perception of their disease, they're oftentimes non-compliant, and they have little bronchospasm because they take so much beta agonists that they're just tolerated to it. They respond very slow to therapy, and they often end up intubated for quite a while, and they don't do very well. They do well ultimately, but they don't do well in the short term. And then there's this guy. He's the young guy who has never had a big attack before. He's totally normal. His family's like, he only has mild asthma. We don't understand what happened. This is called acute asphyxic asthma, and it happens